Thank you for that kind introduction. You've also set a really good base level of where to start talking from. For those of you who don't know about the Royal Hospital for Neurodisability, we are a national hospital based in Putney, and we look after patients who have had severe, and by severe in this context we mean profound brain injuries. So we're looking at people from being in a disorder of consciousness to emerging from that. But when we think about what Jenny and Lucia were talking about this morning with PTA, a lot of our patients will see them weeks, maybe even months, sometimes years after their brain injury, and they're still not laying down any new memories. So their cognition is impaired to a profound level. So we're thinking about not necessarily the severity of their injury at the time that it happened, whether that's their stroke or a traumatic injury. We're thinking about the consequences that these people are left with and how we support them. So I work on the Level 1 Neuro Rehab service as well as the Neurobehavioural service at the Royal Hospital for Neurodisability. And today I'm going to be talking you through my PhD that I completed 3 years ago now, where I was focused on a very clinical issue that I was coming up against, which was for our funders, for referral pathways. Everybody wants a score on some sort of an assessment on a patient. So they ask you, what is the Hospital Anxiety Depression Scale score? What is the PHQ-9 score? And I was finding it almost unethical to go into these patients' rooms and ask them these questions and getting very frustrated. So out of that, I essentially I started talking about the problem, and Professor John Evans at Glasgow said, that sounds like a PhD, and I said yes, so I will go through where we got to with that. All of us know that low mood and depression are common after brain injury. There's loads of papers out there on that, and that clinical interviews and self-report screening measures are the sort of gold standard recommended way that we should be assessing these. Now, we do have guidelines out there that tell us if somebody has communication problems, that these need to be adjusted, whether that's using a yes-no response or pictures, but what's not actually explicitly accounted for is if they have impaired cognition. So self-report, when there is persisting cognitive and receptive communication problems, is really, really challenging. So self-report requires an ability cognitively to think of the past, to compare mood states over a period of time, to compare whether something was a low mood versus normal versus something that was adjustment-based and could be perceived to just be a normal human reaction. And comprehending abstract concepts. So if we think about one of the mood measures that has the idea of it was to be designed for more impaired patients, which is the DISCs that Lynn Turner-Stokes designed. That paper was never able to be validated on people with very severe cognitive impairment because it was still too complex to say what circle shows what you're feeling mood-wise, how dark is your circle, how big is your circle. That's quite abstract when you're asking somebody with profound cognitive impairment. And the other issue we have is actually there's a really big overlap of symptoms. So there's an overlap of symptoms with brain injury and depression to begin with in the more mild to moderate range, but in the severe range it's really complicated because we see people who are fully dependent on hoists and others to be able to perform any activity of daily living. They might not be able to talk at all, or if they are talking, they might not be reliable, and we're sort of trying to tease apart what am I seeing that's actually neurological sequelae of the brain injury, and what am I seeing that might mean there is an additional mood issue present that could be treatable. In press at the moment, Dr. Jai Carmichael and I have a paper which we co-wrote with 15 others across Australia, Scotland, and the rest of the UK. All people who have been doing years and years of research into assessing mood after brain injury, where we're trying to spell out what the problem is in this field, because sometimes it feels like it's solved, but I think what's coming up clinically for people is actually it's really complex when there are issues with communication and cognition to assess and accurately treat these patients. So what we created here is just having a look at symptoms of brain injury, symptoms of depression, which ones would overlap, which is the big bit in the middle with lots of little things listed. And when you look at what's actually really separated for depression, other than the depressed or low mood, which ideally we would want a subjective report of that, feelings of worthlessness or guilt and suicidal thoughts or ideas or attempts, those are all things that you would need to ask somebody about. They need to be able to tell you about them. So we don't have access to them when there is severe cognitive and receptive communication difficulties. So like I said, at RHM, we are supporting those people with severe consequences after ABI. So we see the most profoundly impaired patients, and for us, it's our bread and butter. But we do recognise that in the community, maybe in the acute settings, that these patients often get labelled as unaccessible. It's something that I think there's a few Putney people in the room that we would disagree with quite strongly. Like, everybody is accessible, it's just you have to sometimes get creative. There is very limited literature available on this population. They often get excluded. So, for example, Jenny and I have done some work together, and when we look at how she looks at severe brain injury, their papers often exclude the patients I'm seeing. So they'll exclude them on the basis that they can't perform measures, or they're unable to complete an interview, or they're unable to give capacity to consent to the study. So those are the people that we're working with, where the paper might say that they have done this work with severely impaired patients, but they're still missing this population. And it sounds like it's very niche, but as it was pointed out earlier, actually emergency departments are saving people a lot quicker and intervening in a lot more catastrophic injuries, so we're seeing this population grow. Assessment in this population and screening, according to what the guidelines are, remains as relevant, because if there is something like a mood disorder present, there is treatment available for that, and we should be offering that treatment appropriately. There is a risk of under and over diagnosing this population, but if treatment is available, we should be looking at doing everything we can to promote quality of life. The other issue is usually a sort of knee-jerk reaction to when self-report isn't available is that you should use clinician report, but actually with that symptom overlap, it's quite challenging to use observer measures. And also, a lot of people don't have experience with this patient population, so they might mistake what they're seeing. And the other thing is just to mention that measures do not always seem to fit with the patient experience, because I think we get a lot of looking at the gentleman in that picture. His name is Jeff. This is a picture from The Guardian. He was one of the patients who was hospitalised the longest during COVID, when he had a COVID-related stroke. And he looks very depressed there. People often say he's miserable, he's upset. He's just thrown up. That's what that picture is. But the newspaper did report all about his distress. He wasn't depressed. He was actually did the HADS for me because he was fairly cognitively intact, and he said that this is the most inappropriate bunch of questions I've ever been asked. I'm in hospital. Of course, all of this is how I'm feeling. I'm not depressed. This is just because I'm in hospital. So he was a good motivator to keep going. So in terms of what I aim to do with a PhD, I wanted to know whether any of the mood measures out there have ever been validated on this population. I know that my colleagues are seeing these patients and that we are assessing them and that we are working together, and I work closely with neuropsychiatrists who are prescribing medications. So what are we all doing? What's the common clinical practice? And then I was just keen to see, can I actually gain a consensus and make sense of this? So in terms of the systematic review I did looking at whether these measures had been validated on this population, it was a rather large systematic review, as you can imagine, searching for mood disorder and brain injury and outcome measure. It was 22,000 papers I had to look at. And it was only 25 papers that got included in the end that did not explicitly exclude patients with severe cognitive impairment, and only one paper actually included them. So in the blue circle, you've got a mix of measures that were completely valid, reliable, and adequately researched in a mild to moderate or mixed severity population. But the green circle are the only two measures that have been validated on patients with severe cognitive and receptive communication difficulties. It was a paper with 25 participants, and it was a little bit too small to make anything generalizable. What we can say is that most of the measures and no self-report measures have been validated on this population, so ideally we shouldn't be relying on them, and that there are two observer-rated ones that we can tentatively recommend, but again, it would have to be used with that bearing in mind all the complexities around the area. So after I had a look at what had been validated, I then surveyed medical professionals, so rehab clinicians, ward doctors, neuropsychiatrists, as well as clinical psychologists working in the field, and asked them, what do you do when there are profound cognitive and receptive communication impairments? And what came out the most is that they speak to others. So already a picture of this person's not reliable, they can't speak, so I need to speak to somebody else about this. And one of the things that we often have a concern about is that we're then asking people who are not experts in mental health to give us mental health symptoms. And we're still trying to pick through what family members are saying or carers and trying to work out, is this cognition, is this neurological, is this actually mood? But they speak to others. They do reassuringly still speak to the patient, which I was happy to see. And the clinical psychologists made use of standardized measures, medical professionals less so. And when using those measures, actually most of them made adaptations to either the administration or the scoring. So the fact that they're taking a standardized measure and they're not using it in a standardized fashion, or they're not using the score because they don't think it's a reliable score, tells us that it's not serving the purpose that we're using it for. I then progressed to interviewing people who did the survey who agreed to further studies, and I wanted to know in detail sort of what they thought was going on when they were doing these assessments and some of the problems they came up against. The symptoms that clinical psychologists were looking at were sleep, appetite, tearfulness, interaction and engagement, so things that were slightly more objectively observable, and very focused on looking at consistency and chronology of the symptoms. So did this start only after the brain injury? Has this gotten worse as the weeks have progressed? Because that might give you a bit of a clue that something, we're generally expecting an upward trajectory after the brain injury, whereas if there's a downward trajectory, perhaps there's something else at play. There was a lot of discussion about the issue of the construct of depression after such a severe brain injury. So a lot of discussion around when somebody's cognition is that impaired, is it truly depression? Are we really thinking about the sort of cognitive affect models of depression? Are we thinking about chemical models of depression? What are we working with here, and how should we be conceptualizing this? There was a concern about pathologizing normal emotion. So a lot of pressure to screen then often puts people on a pathway with a label very early on, but actually the tearfulness they're experiencing could be lability of emotions, but it also could just be they've had a very severe and traumatic experience, they've been in hospital for a while, they've just arrived on my ward, and I've pulled out something that's going to give them a diagnosis rather than giving them space to speak. They highlighted that their assessment processes include adapted interviews, getting the collateral from others, observations, assessing over time and at multiple points, so an acknowledgement that these assessments take quite a bit longer. The use of formulation, and I think I'm in a room where everybody here has learned about formulation, but it is also a specialized skill that not all of our MDT know how to do. So I think that was something that was a really interesting theme that came up across both the clinical psychologists and the doctors. And highlighting again and again and again that because the responses aren't reliable, standardized measures won't be reliable, and that actually they're using them because systems tell them they have to, or they're using them because they don't know what to do and they just want a little structure of where they should go in the conversation, but actually they're not really reliable enough to be used at all. With the medical professionals, they had a very similar assessment process, but they also focused on ruling out other biological causes such as pain. They didn't routinely make use of standardized measures and actually had more confidence at times in looking into sort of a diagnostic differential. But again, that would be reliant on other people's feedback from the team and thinking about how reliable the team is understanding the symptoms that they're seeing. All of the medical professionals felt that there was a role for medication if treatable symptoms were identified, and medication choices were based on either preference and experience with a specific medication or trying to address other symptoms that are present that an antidepressant might address. So mirtazapine might help with appetite and sleep, for example. All of the doctors had a huge concern about stopping these medications. So when somebody's being seen by the GP for the rest of their care, if the GP is not going to be able to assess, it's likely that they're going to stay on these medications for the rest of their lives and not have that reviewed appropriately. So I had an idea of what everybody was doing, and it overlapped quite a bit. I could see that they were using similar languages, there were similar frustrations, so I thought maybe it would be possible to reach some sort of a consensus. I did have dreams of making a measure, but everybody who's done a PhD knows that you have to adjust your expectations. So in terms of focus groups, I got anybody who was willing to be contacted them again, and I completed 5 focus groups, which was predominantly clinical psychologists seemed to have more time than medical professionals, so it was 14 clinical psychologists and 2 medical professionals. And I used an approach which was a really structured, ordered, nominal approach to a focus group so that everybody had a chance to talk. So rather than a huge conversation that you're trying to then analyze, you're giving everybody a chance to have an opinion on the question and then ranking their opinions. So that at the end, we ended up with a process. And really, really happily for us, the process overlapped and almost everybody said the same thing, just with different language. So we were able to present what we called a formulation-based model. So essentially, I like to think back when I started the PhD and John asked what would the ideal be, and I said the ideal would be is that you put a neuropsychologist's brain on a piece of paper and you say you do that, you do the formulating. So that's what we've tried to do. You'll see it's very complicated, it's very wordy, and I think part of the early reaction to that was wanting to simplify it quite a bit, but then becoming comfortable with actually this is quite a complex process and it's a timely process, so this probably is capturing all of it. But the next stage was to try and see, okay, these 14 people came up with this, can we get a broader consensus? So some of my postdoc work has looked at a Delphi study, which I'm in the process of writing up at the moment, and this was done online, where each step of the formulation model was separated and they were asked to give feedback on each piece, rate how useful it was, and provide comments as well as if they thought that something should be markedly different or left out. We agreed that consensus had to be that 80% of the experts endorsed the highest 2 ratings, and we approached people that we knew were experts in the field. So we approached, the Jenny Ponsfords, the Dana Wongs, people who we know have been doing this for years, and also are very vocal in the field. So the feedback that I got from the first round is actually 28 of the 33 items of the model were agreed on, which was great. Feedback was given on the visual representation, which wasn't surprising. Like I said, I myself thought it was very busy. And what we then did is we simplified the model from the feedback that was received in the first round and presented it in a second round. It was also suggested that perhaps a more simplified workflow, so instead of having the complicated formulation cycle, having a workflow to direct a clinician through it might be helpful. It was suggested by a number of people that a manual would be needed to feel confident about using the formulation model, so this was created for feedback. And then the 5 items that needed clarification were represented with more information. And I've just finished analysing the results of round 2, and we've got agreement on all 33 items now. The simplified model and the horizontal workflow and the manual were all well received, which is excellent, and there is no need for further rounds. So I'm currently writing that up. Hopefully before I pop that will be off my desk. So in terms of a simplified model, this is what was suggested. This is how we've sort of brought it down to its sort of most salient points. So the way the model works is that you're sort of starting at the red box, which is an immediate response to acute distress needed. So the expectation there is I'm not thinking that you need to do 2 weeks of mood assessment if somebody is actively so distressed that nobody on the ward can support them. That is a different intervention. That's not likely depression we're dealing with, and there's a different medication choice, there's a different therapy choice, there's a different interaction choice there. So if it's not an immediate distress, then use the formulation-based model. If it is, then you're thinking about your medication choices, you're thinking about your environmental supports. And the model itself has the sort of pre, peri, and post approach. So pre being getting all your collateral information and the information you need. A lot of it has been mentioned today in terms of pre-morbid mental health, recovery, the GCS scores, PTAs, all the information that you need to inform your assessment. Peri is the actual assessment itself and what you're doing, and post is what the formulation is based on, which is your hypothesis testing. So you're sort of working on the balance of probabilities. Am I thinking this is mood? Am I thinking this is cognition? What evidence have I got? And what intervention am I going to use? And if you are using an intervention, monitoring the response. So thinking about what the guidelines say is usually 6 weeks of medication intervention. Therapy-wise, we would expect probably an earlier, quicker response, but thinking about you've established what the baseline symptoms are, I'm going to do an intervention, you need to reassess and reformulate if necessary. That's just a little bit of the manual and the horizontal workflow that will also be included as part of the formulation-based model. And once that's done, we've got some ongoing work and future projects. So I remain an honorary research fellow at the University of Glasgow. Like I mentioned earlier, there's a position paper coming out with international experts looking at this issue and just sort of highlighting what's going on in the field and the fact that Dr. Carmichael and I have both done research in this area and are trying to progress it further. And that international working group where we've written this paper with, we actually are trying to create a measure. So we have done the ethics and we've done focus groups with clinicians, and the next stage is to do focus groups with those with lived experience of ABI. So in summary, the assessment of mood when there is severe cognitive and receptive communication impairments remains complex. Standardized measures haven't really been adequately validated, and they should be not used, or if it is the observer ones, used with caution. We suggest a formulation-based model. and an international working party of various MDT members are working on a measure to try and fill this clinical gap, so watch this space. And just to end, I'd like to thank my PhD supervisors, my colleagues at the RHN, the funders of my PhD, and also there's a number of people in this room that completed my study, so thank you for your time.
Great, thank you, Alex. Really interesting talk, and we've got 4 minutes for questions. Romy.
A couple of quick questions. Can you learn anything from assessment of mood in patients with severe dementia, which would inform what you're doing? And the second thing is that sometimes you just don't know whether it's depression or cognition, and you might empirically trial therapy, but then how effective is therapy? So maybe, it doesn't work because they're not depressed, or it doesn't work because the therapy doesn't work. And maybe you could help with that.
Yeah, it's a lot of it's a sort of Schrodinger's cat, not sure if it is or it isn't, and I'm not confident that we'll necessarily ever get to an answer because of the subjective nature of a lot of this. I think when it comes to the dementia, I used to work in a dementia service with Dr. Foley in the back there, and I think a lot of the same problems came up, but the difference being that the cognitive processes were more streamlined to specific areas, whereas in profound brain injury, it's beyond memory and language, and it becomes a lot more just executive and insight-based as well. In terms of yes, we don't know what treatment works. I think what we find that this is also trying to address is that we're not clinically very robust at measuring what's working. We're sort of sometimes very siloed in the approach, and we all have an idea about what might work, but we're not, as a team, looking at, okay, I started medications, I've started therapy, is it improving, and what are we expecting to improve? So are we trying to look at the person who is unable to initiate eating and seeing, is this because they've got no appetite because it's mood, or is this actually frontal lobe dysfunction and they need hand-over-hand support? So it's trying to encourage formulation and trial and error and being more robust about it to be a little bit more confident. But I think a lot of finding out whether it is or whether it isn't is almost like an ethical or theoretical discussion that doesn't really drill down to what the patients need.
Vaughan, have you got any questions online? Or no? Jonathan, did you have a question?
Oh, hi. I was just wondering if you could give us, me anyway,